Hi everyone. So I'm doing a quick video here regarding doing a patient review. So from my experience, patient reviews have always been very helpful to facilities, and this also helps communicate what we're doing for the patients and why they should continue to refer to us. Okay, so this is very important. So I'd like to revamp how we're doing these patient reviews for several reasons. Number one, we need to really focus on the diagnosis and why they're on hospice for, or what diagnosis they are qualifying under hospice for. Part of this is because we need to be able to show why Medicare is paying us for these services, okay? So when we present a patient review, a lot of times we need to be able to go and present a mini IDG in a sense, and it needs to be really organized well so that it sounds professional, and we just don't go in and say, hey, they're just doing fine, and some of the people that are attending don't even know the beginning and the end of the story, and we're just saying they're fine, they're drinking their Coke, and we're okay. So that's really not the goal. So what I'd like to do is outline a process and a step-by-step on how we're supposed to present our patient reviews, okay? So mainly, it's going to be a mini IDG. This is mainly run by the nurse first, and then it goes through the different disciplines. So patient review, I wrote a few things here. Okay, so the first point is we need to paint a picture. Paint a picture to Medicare and to anyone listening that they are qualified for hospice. Because there has been a lot of questions on why a patient is on hospice, or are they still qualified. If we come strongly and make this presentation and make it clear why they're on hospice, then there's no question about it. It also helps us to evaluate our process and whether our interventions are actually working. Okay, so it needs to be presented as like a mini IDG. Okay. So what is the main thing? The first thing I'm really focused on is it needs to be hospice, pardon my writing, diagnosis related. Okay. This is always the first thing we need to focus on. When you have a patient with COPD, you don't start talking about their bowels. We need to start talking about how their breathing is. Are they on oxygen? How are our interventions? Do they need education on how to take care of their lungs and when to use oxygen, et cetera, et cetera? We need to be going through this process. So when we look at hospice criteria, there's always two categories. One is the signs and symptoms related to the diagnosis, okay? That has to be our first focus. The second is non-hospice related declines. So it could be, the non-specific stuff, losing weight, getting weaker, getting more confused, which may or may not be related to the hospice diagnosis. But I don't want to start with all the other things going on without addressing first why they're on hospice and what their diagnosis is. So please talk first always about diagnosis related things. And then you can go to, and I'm referring to the nurses, and then you can go to a non-hospice decline. So for example, I would say, okay, we have a patient on for heart failure. Recently, he's had no significant changes in his edema, and his not requiring oxygen. He's not short of breath, but he does at rest, but he does need to sit up and has more orthopnea when he sleeps. So you have to go through the gamut of addressing all the hospice diagnosis related symptoms first, and then explain what interventions you're doing, and then explain if they're effective or not, and then going from there. And then after that, you can start talking about, okay, non-hospice related, diagnosis related things like how are their bowels moving? Are they having any joint pains, or et cetera, et cetera. So you get the idea. It needs to be organized in that manner. And then we go down then to the next, the disciplines. So after the clinical stuff is discussed, then we go to spiritual and social work. Okay. So, we talk about addressing psychosocial needs, paperwork, that they need help with social work, everything else that happens interdisciplinary. So we don't want to be popping around back and forth, going back to clinical and then back to spiritual and then back to, so it would be nice to go per discipline in an orderly fashion. Special mention to complementary therapy, of course, is one of the disciplines. That's one of our strong suits, and it's good to keep in mind that complementary therapy addresses both physical as well as psychosocial needs, since it's got many aspects related to it. And then I think at the end of each patient, we need to open it up for discussion where we can involve the facility people. So remember, we always have to collaborate. The reason for the patient review is so that we can say, okay, this is what's happening with the patient. This is what we're doing. These are our interventions, and they're helping or not helping, or we need more troubleshooting. Therefore, you can go through the different disciplines, address all these issues, and then have a discussion afterwards. And that discussion needs to be in conjunction with the facility. We can't be telling them, like, we're doing this and this and this for this patient, and then never involve them, because they're part of the process, right? So especially nursing and clinical is very prescriptive. Well, they need to take their morphine. They're not taking their morphine. But, who gives the morphine? We need to involve the facility. So this is the opportunity. Remember this, patient review is the opportunity for us to address all the issues with the caregivers. We need to walk side by side with them so we can care for the patient and the family. Okay? So I think I talked enough about the why, So why, just remember, why are we doing this? Number one, we need to collaborate with the facility, and it's not in this order, but I mean the first thing is to create a really organized picture of what's happening with the patient, be able to present that in an orderly fashion, and I would like it to go from clinical, hospice diagnosis, and then going through the disciplines, and then discussing with the facility. And then when we do this, we also are able to create documentation that represents why this patient is on hospice. I don't care so much about all the other information that comes out of these patient reviews if we're not addressing the primary reason they're there for. You know what I mean? So we can talk a lot about such and such patient is happy with what's going on with the family and blah, blah, blah. But then we never talk about the hospice diagnosis and why they're still on hospice for that. And because, as you all know, we've changed diagnosis at times, and sometimes it's not appropriate anymore for dementia. Maybe it's a different reason that they're declining. So this is a quick video, which I just like this to be kind of a springboard for when we do patient reviews. We need things to change. I would like to see patient reviews going more efficiently, addressing these issues that I've outlined. Also, to make it easier, we are currently working, the management team is working. I want to put a step-by-step list on how this whole patient review should run. So we'll give you kind of a checklist, and we need to follow that order, and that will make it easier so you don't have to worry too much about that. So we're working on that, but until we can get that finalized, because I want all the disciplines to give their input. I don't want it to be just about what I think. We need to just organize the patient review. So this is just the preview of how we're going to do this. And again, we'll be working on a form so that you all have something to follow, and it'll be like a mini IDG. Okay? So I hope that helps. Thank you for listening.